Finishing up with grief and loss, we're going to talk about the types and sources of loss, what manifestations of grief are, alterations to grief. When you are looking in your book, refer to chapter 9 in your Ignatius and Workman, and as well as concept 49 in your conceptual based Giddens book and chapter 41 in your woman's health book. So when you think about death, death is it's a normal part of life and it's part of life cycled, but it's really a very fearful time for a lot of people. And the number one fear associated with death is actually the pain and suffering that can accompany death. It can be life altering for those who remain, especially if it is a significant loss. So, a child, a husband, a wife. If it's some type of traumatic event, so maybe a suicide or someone has died in the line of duty, or it could be that the patient has suffered for a very long time and now the death has ended that lifelong suffering. So, nurses, we really play a huge part in a person who is experiencing death. We spend the most time with our patients, and we have ample opportunity to open doors and offer time to communicate with them. So when you think about that, you think about the physician coming in and the physician talking to the patient, asking the patient how they were, talking to the family, asking the family how they are. Really, the physicians sometimes spend 10, 15 minutes in the room, whereas we as nurses will be in and out of that room in the hospital setting all day long. When you think about an acute hospice inpatient program, we're in and out of the house. If you turn your attention to home care, then thinking about going into those homes and talking to the families in the homes. So we play a huge role in our patients' grief, loss, and dying. And really in 1995, the Institute of Medicine started studying death in America, and the focus turned to how to achieve pleasant deaths and how to achieve a good death. So when you look at death and dying, a good death is peaceful and meaningful. And a bad death is the person dying without dignity, without purpose, without feeling like they fulfilled something. So, with death, obviously there's cessation of integrated tissues and organ function. And what you will typically see occurring first is cessation of respirations, and then the heartbeat is soon to follow. Death can also occur due to a traumatic brain injury, to anoxia, asphyxia. So there's irreversible brain dysfunction. Right now in the United States, the most common cause of death is heart disease, and then followed closely by cancer. Death related to heart disease is due to heart failure, secondary to some type of cardiac dysrhythmia, acute MI, shock. After those cardiac events, then what we see typically are renal and renal failure, respiratory changes, maybe respiratory arrest. We might also see COPD, pulmonary embolisms. Another traumatic death would be due to a trauma, maybe a severe infection or blood loss. So, as nurses, our response, how do we behave? How do we act? Nurses need to act with compassion. And when you think back to Florence Nightingale and all of the good that she brought to nursing, she also not only brought help with dealing with infection rates and getting people into better homes and living environments, but she also had compassion and empathy for her patients. So I believe strongly and firmly that part of our role as a nurse, and I think it's partly inbred in us, is that we are compassionate people. We know how to show empathy. We also need to be patient advocates. So if we feel like our patients aren't dying that dignified death, we need to do something about it. Therapeutic communication with our patients as well as their loved ones, and we need to have knowledge about end of life. So when you're looking at the physiologic changes, referring to either of your textbooks, what you will see are cool extremities, increasing sleeping. You will see the fluid and food intake begin to decrease. Oftentimes it's associated with incontinence. And that's just due to the changes in the neurologic and um, neuropathic ways. We'll see congestion due to heart failure, the death rattle, so changes in breathing patterns, maybe some periods of apnea, agonal respirations. We will see disorientation and restlessness. Emotional changes that we might see are going to be withdrawal. Some people have visual changes, so maybe some hallucinations. The patient really feels the necessity to say goodbye, have that sense of that they're letting go. So with death, then that's when we're going to see spontaneous respiration cease and then the heartbeat cease. So we need to talk about postmortem care and the nursing process. So we'll spend some time talking about those. And when we are dealing with death, we need to think about management of symptoms. So we need to think about drug therapy. We also need to think about psychosocial support. And when we focus on the psychosocial support, we will talk about just our presence with our patients when they're dying. Hopefully we offer our patients a time of life review, offer them time to reminisce about their life processes. We also need to consider spirituality and religion. And remember, earlier in lectures I've said that spirituality and religion are different things. It's not necessarily just the focus on God and church. It's all of the everything else that's put together to make that person whole. Fear and anxiety are going to be huge issues that we need to help those patients with. So not only just administering anti-anxiety medications, but also administering that support that they need. So being beside them, allowing them to express their feelings, allow their significant others to express feelings, and then also we need to consider the cultural considerations that are associated with death and dying. So the different categories inside of death and dying: hospice care, symptom management, supportive care, comfort care, and end-of-life care. So basically all of this focuses on the care of the patient, not on the cure of the disease. So when we start talking about palliative care can be initiated early in the disease process, and they can still be undergoing treatment and therapies and things like that. But the palliative portion is helping alleviate the other signs and symptoms, the other manifestations, the other coexisting comorbidities that they may experience. So we really just truly focus on how we can help that patient be the best person they can be until the end of life. So supportive care goes right along with symptom management, and we need to take an interprofessional approach, so involving other members of the healthcare teams, so the physicians, therapists, PT, OT, ST, social workers, caseworkers, clergy. So there's lots of people that we can think about to have that integrated approach. Always remember that when we are considering any kind of care, so it's not solely for this palliative or end-of-life care, it's for everyone that we come in contact with. Remember that patient family-centered care is really important, and it's all about quality of life versus length of life. So when people are planning for end-of-life care, typically most people would prefer to die at home versus dying in a nursing home or in a car. Maybe it's a traumatic accident, but most people are going to prefer to die at home. So we need to think about advance directives. And advance directives are written legal documents that are going to provide guidance to the healthcare providers regarding how to make decisions about life-sustaining treatment when this person is no longer able to make those decisions. So a couple of different types of advance directives are a durable power of attorney. And with a durable power of attorney, someone is appointed to make the patient's healthcare decisions if that person is incapacitated or unable to make decisions for themselves. A living will basically includes medical directives. It can include a do not resuscitate or DNR order. Um, when you are considering advance directives, living wills, durable power of attorneys, a person has to meet three criteria. So they have to be able to receive information, but they may not necessarily be alert and oriented times four, but they do have to be able to consciously receive information. They have to be able to evaluate, deliberate, and mentally manipulate information. And they need to be able to communicate treatment preferences. And when you're talking about do not resuscitate orders, do not resuscitate orders are there for persons who do not want cardiopulmonary resuscitation. When we think about DNR orders, we need to remember that they're not do not treat orders, but they are DNR orders. So in fact, when you have patients in the nursing home that are maybe bedridden or have maybe what you would consider a poor quality of life, and they come into the hospital and they're seeking treatment, and we think, well, they're a do not resuscitate, so maybe they should just go back to the nursing home. But a do not resuscitate is not a do not treat, so we do need to continue to treat patients. The DNR is just specifically geared toward CPR. So a DNR order can be written in advance, and we do have portable DNRs. You take them with you. If you are in a particular area in that hospital, it's good to get a copy of that to your healthcare provider. With DNR orders, effects are different according to states, but most people can have a DNR card with them, which will also entail a written legal contract with a physician. And they carry this card to local healthcare facilities as well as a copy of the DNR orders. So when we think about DNRs, they're really great for people who are in end-of-life care or are not wanting life-sustaining measures. But major problems are listed out here that they can be unclear. So sometimes when you get into the hospital setting, you might see a CPR no machines. So yes, please do CPR on me, but don't hook me up to any machines or any type of mechanical devices. So really, are we going to do them any good if we do the CPR in the first place? They can be perceived by family members to mean that they have given permission to end the patient's life. And not allowing a natural death to occur. So there's some variations, but really when you think about a DNR order, fact is, you need to have a DNR order written each and every time that patient comes into the hospital. So if maybe in the past you've taken care of that patient, or you've seen a do not resuscitate contract, or you've seen a copy of their DNR or advanced directives, make sure that you convey that information to your physicians, because sometimes physicians don't see that. And we don't want to run the risk of performing CPR on someone that is a do not resuscitate. I will end this presentation here and continue with end-of-life care's desired outcomes when we continue on.